Thank you very much for having me today. I will spend a bit of time, if I can have my slides pulled up, talking about home monitoring of pulmonary artery pressures, which has been a significant breakthrough, I think, in the development and management of patients with heart failure. My disclosures are now on this slide. When I accepted this lecture, I was and still am a professor at the University of Oklahoma. And now, as of February 1st, I'm the medical director and vice president of St. Jude Medical. As principal investigator of the Champion trial, we helped develop a technology that now is being marketed by this company. And so it was a grand opportunity to not only implant the first device but be involved in the opening of a new market and a new world for an old disease. I think we've learned a tremendous amount of insight about the pathophysiology of heart failure from implanted devices, and I think you've seen this type of information before. And when we actually use the typical signs and symptoms and tools we have to manage patients with heart failure, we really get into this cascade of events that leads to decompensated heart failure very late. So in terms of acutely decompensated heart failure, what we found is that process actually occurs over a long period of time. In fact, it is very clear that the first thing that can be determined and detected is a change in cardiac filling pressures. If that filling pressure change is sensed by the body, heart rate variability changes to suggest vagal withdrawal and sympathetic activation. If that does not take care of the problem, then one can see changes in intrathoracic impedance. And if that doesn't change, then patients decompensate and are hospitalized, requiring intravenous therapy for their syndrome to decongest them. So again, we all know that about 90% of patients who are hospitalized around the world, Western Europe, United States, are congested with good perfusion. And so that congestion process shown here is one that we need tools to get involved earlier in order to prevent the decompensation and maybe change this disease process from a crisis management disease to a maintenance of stability process that can hopefully allow us to monitor patients remotely. If one really critically looks at the tools that we have to manage patients with heart failure, you see the tool, the parameter on the left of this table, and you see what we're doing to try why we do the maneuver or measure this blood test or a test from an implanted therapeutic device. And almost always those maneuvers are to try to estimate cardiac filling pressures. In fact, their B-type natriuretic protein, for example, was validated based on a correlation with pulmonary capillary wedge pressure. Intrathoracic impedance was validated with pulmonary capillary wedge pressure. So all of these maneuvers are designed as surrogates for cardiac filling pressures. So with the advent of new technology, we felt that the hypothesis could be developed that if we could just directly measure the cardiac filling pressure, the lesion of the disease, it might be a better way to manage the patient rather than using a surrogate like physical examination or daily weights. And the other is that each of these checked areas are parameters that require the patient to be in front of us or come into the lab to have a BNP drawn. So the vast majority of things that we use to estimate cardiac filling pressures require the patient in our presence. Not only that, but this work from Lynn Stevenson and those of us involved in the COMPASS HF trial demonstrated that there is a direct relationship between cardiac filling pressures and the risk for a subsequent heart failure hospitalization. And the zone of stability that has been detected or determined by these studies is a fairly narrow zone, as you can see here, from an estimated pulmonary artery diastolic pressure from 16 to 22 to 24 millimeters of mercury. So those tools that I had on the previous slide really don't have the sensitivity in order to identify this zone and allow us to maintain patients who have heart failure over time. So again, with the advent of new technology, we hypothesized that if we were able to directly measure that, we would do a better job of managing patients, preventing them from decompensating, keeping them well and outside the hospital. So the CardioMEMS sensor, the PA pressure sensor used in the CardioMEMS heart failure system, is a new technology and is a micro-electromechanical system. So micro-electromechanical system, or MEMS-based technology. It does not have a lead, nor does it have a battery. It is empowered by external interrogation. So the external antenna as part of this system interrogates the device. That's what empowers it, so that this tiny device can be permanently implanted in the pulmonary artery. The patient can go home and use a home electronics interrogation unit, and that unit then can upload the pressures measured by the sensor into a website that the providers can now manage and look at and actually see those filling pressures that we're trying to estimate with the other parameters that we use in clinical medicine. The CHAMPION trial then was designed in the United States as a multi-center, prospective, randomized, single-blinded trial to test the hypothesis that heart failure management might be better if medical management was based on remotely obtained pulmonary artery pressure. So pulmonary artery pressures measured at home, allowing the provider and the investigator to actually treat the pressures and adjust medications to lower those pressures to a zone that would maintain stability and then react to changes if they were to occur. So the outcome then would be to improve the quality of care by decreasing heart failure hospitalizations. I'd like to go over the data from the CHAMPION trial and give you new data that we presented just a couple of weeks ago in San Diego at the American College of Cardiology meeting. Very interesting data, I think, that was a bit of a surprise to me, at least, when we did this analysis. But I want to remind you what the CHAMPION trial was. It's 550 patients in 64 centers in the United States. Patients were implanted with the sensor that you saw. That sensor is implanted through a right heart catheterization from the femoral vein, with an over-the-wire catheter delivery system that actually places the sensor in the pulmonary artery. Once implanted, it becomes endothelialized within 30 days, so dual antiplatelet therapy is continued for about 30 days, and the system then is out of the bloodstream. So there's no nidus for infection, no in situ thrombosis, or other problems associated with implanting this in the pulmonary artery. Once implanted, patients were randomly assigned to a treatment and control group, in which the treatment group, all standard of care medical therapy for patients with heart failure, were extended to those patients, in addition to using the uploaded daily pressures. In the control group, the patients uploaded the pressures, but the investigators were not allowed to see the pressures and manage these patients based on standard of care. The primary endpoint was rate of hospitalizations. We assessed that at 6 months, but each patient stayed in their randomized group until the last patient finished 6 months of follow-up, and that allowed us to see if this was a long-term effect, if there was one, that might be robust over time, or if there was fatigue, or how long could this effect of reducing hospitalizations last. And you can see numerous secondary endpoints that I probably won't spend much time on. The primary results of the trial actually were published several years ago now in Lancet, and I've just shown this for completeness sake. I'm going to get to some of the new data in just a moment. But you can see that first, the safety endpoints of implanting a device like this in the pulmonary artery. There were 8 device or system-related complications out of 550 patients implanted with the device, a very low complication rate. And thus far, we've seen no sensor failures out to about 8 years of the longest patient implanted in the trial and actually in the feasibility studies. So no sensor failures and very few device or system-related complications. The efficacy endpoint, again, were heart failure-related hospitalizations at 6 months, and you can see that there was a significant 28% reduction at 6 months. But if you look out through the entire follow-up period, again, a randomized assessment over a long period, one can see a total 37% reduction in hospitalizations when patients were managed with pulmonary artery pressures directly measured by this sensor that was permanently implanted in the pulmonary artery. So a 37% relative risk reduction for heart failure hospitalizations over a long period of time. Now, how was this done? Well, we monitored how the investigators behaved. So they were to review the pressures, and then if they changed a medication, they had to tell us why they changed that medication. So they filled out a case report form saying that we changed this medicine based on pressures or symptoms or other parameters. And you can see that in the 6-month follow-up period, there were 1,404 additional medication changes based solely on the pressures that were uploaded, again, from the patient's home. These pressures were uploaded daily and reviewed once a week. And that led to about one medication change per patient per month based on the uploaded PA pressures. Now, the inclusion-exclusion criteria of the Champion trial did not have ejection fraction as a criteria. So 22% of patients had heart failure, previous hospitalization, New York Heart Association Class 3 symptoms with preserved ejection fraction, defined in this study as ejection fraction greater than 40%. We were very interested to find out if this management strategy would be successful in patients who have preserved ejection fraction heart failure. So that was a predetermined subgroup analysis, and you can see the long-term follow-up in the preserved ejection fraction group is shown here, with at 17 months of follow-up a 50% reduction in the need for hospitalization. So this represents one of the first strategies clinically to manage patients with preserved ejection fraction that actually is successful. As you know, there is no consensus other than managing volume and blood pressure in patients with preserved ejection fraction. So there's no medication group or any other consensus in that population. So this is a very gratifying result that was also associated with an increased number of diuretic changes, particularly in this group of patients. So the latest data that I want to update you with, this came from the American College of Cardiology, a retrospective subgroup analysis in the Champion trial. And I'd like to spend the next 3 or 4 minutes discussing this with you because I think it's a very interesting study. So one question that people have had over time is, if you simply use the maximal dosages of all guideline-directed medical therapies for patients with heart failure, you wouldn't need to use pressure sensing. You wouldn't need that parameter. You wouldn't need that tool. If you just used all the medicines that we know help patients with heart failure, you wouldn't have to have pressure monitoring. So we asked that question. We looked at patients in the Champion trial with reduced ejection fraction for whom there is a consensus about how they should be treated, and looked at patients who had medical therapies and were not intolerant of those medical therapies in their care, and then performed several analyses that I'd like to show you. So again, these are reduced ejection fraction patients who are on guideline-directed medical therapy at maximal dosages. 337 patients then met those criteria, and one can see at baseline the medical therapy and their dosages in this table. The green areas represent the guideline-directed medical therapies, ACE inhibitor ARBs. The ACE inhibitor ARBs are in enalapril equivalents. The beta blocker is in carvedilol equivalent. Aldosterone antagonists are in spironolactone equivalents. So you can see that the enalapril equivalent in this group, for example, is 19 milligrams daily, which is actually a little bit higher than the SOLVE trial. So this is a very good group of good medical therapy for a group of patients that were symptomatic and at risk for subsequent hospitalization. The first question we asked was, if we maintained their stability and contracted their volume and controlled their volume with pressure-guided care, were we able to further maximize their guideline-directed medical therapy? And we found that was the truth, that not only were a significant number of nitrates added to these patients' medical therapy, but the ACE inhibitor beta blocker dosing was actually improved significantly in the treatment group. That couldn't be done in the control group. And again, these patients had to be maximally treated in the investigator's opinion before they could even get in the trial. So this is an interesting finding that they were able to up-titrate medical therapies, life-sustaining medical therapies, better when their care was based on pressure-guided management. Our first question was then, does pressure-guided care in patients treated with guideline-directed medical therapy affect their heart failure hospitalization rate? And here you see the results. In this group of patients already receiving maximal drug therapy, 46% reduction in hospitalizations was found. A gratifying, again, retrospective analysis, but very much in line with the primary results of the trial. 43% reduction. But the somewhat surprising thing that we identified in this analysis when we looked at mortality is shown here. This analysis demonstrated a 57% raw reduction in mortality in this group if they were in the treatment group. Now, there were some baseline differences between these control and treatment groups, and after a multivariate analysis, the reduction in mortality was 50%. So what we see here is a dramatic reduction in mortality if we're able to maintain stability and decrease hospitalizations. So to summarize, the primary results of the trial were published in Lancet. The preserved ejection fraction patients experienced in circulation heart failure with a 50% reduction in heart failure hospitalizations, and with secondary pulmonary hypertension, data I didn't show you, but a significant reduction in that group as well. So this system not only now we believe has an effect on heart failure hospitalizations, but by preventing heart failure hospitalizations and maximizing guideline-directed medical therapy, we're now seeing a signal that mortality can be affected by maintenance of stability using this strategy. Thank you very much for your attention.